one of these questions was about the definition of the complicated and uncomplicated stress urinary incontinence. This is really a hot topic. The definition can really change in different minds according to different physicians and individuals. And in the literature, there is also still some controversial discussion going on that. Can you please start just what the AUA guidelines say about the uncomplicated and complicated stress urinary incontinence and how they define it?
Yeah, thank you so much for that, Tufan. Actually, when we think about uncomplicated stress urinary incontinence, this is the index patient, and this is exactly what our guidelines are focused on. We do have an enormous number of information given in our guidelines for the AUA about evaluation, treatment, and we also mention special cases that we will discuss later. But in reality, these guidelines were built for the index patient. And the index patient is an otherwise healthy female who's considering surgical therapy for the correction of pure stress or stress predominant mixed incontinence who hasn't undergone any prior stress incontinence surgeries. They did allow for some very low grade pelvic organ prolapse, but in general, the index patient is one that we actually rarely see in the clinic that the guidelines were meant for.
Yeah, really, this is very crucial to differentiate the complicated ones. And we also know that, especially if you are working in a referral center, almost all of your patients will be complicated ones. Really, in the clinical practice, the majority of our patients are not index patients, and they are complicated patients. There is a recent publication from the ICS Urodynamics Committee. This is actually a teaching module about the utilization of urodynamic studies in the assessment of female urinary incontinence. And this teaching module especially indicated some points that can be easily overlooked during the assessment of our patients. But these points actually put the patients into the category of complicated patients. Therefore, we have to be careful in the assessment. For example, if we observe low volumes in the bladder diaries of our patients or in the repeated uroflowmetric tests, this is something that should be further assessed by multi-channel urodynamic studies. Like also high residual urines, I think we all agree on that. Recurrent UTIs can easily be overlooked, but I think this is also an important point that brings or upgrades the patient to the complicated category. Pain is something that we have to very carefully differentiate. And medications, especially with aging, most of our patients are under polypharmacy, and this can affect the function of the bladder and maybe sometimes a cause or actually an influencer of the lower urinary tract dysfunction. And pelvic organ prolapse, as you said, especially after a failed surgery for either incontinence or prolapse, is another factor that shows us that our patient is complicated. And also, if you have a patient with a complaint of the stress urinary incontinence, but if you cannot show it on your physical examination, I think this is also an important point that we need to consider. And actually, so we do the urodynamic studies. Why are we doing this? We try to find certain urodynamic diagnoses and pathologies that may affect the treatment outcome and also our decision making for that. What can be diagnosed with urodynamic studies? This is again shown by this teaching module. For example, we can diagnose a low bladder capacity. We can diagnose detrusor overactivity of different types, either with urinary incontinence or without urinary incontinence. Or we can diagnose bladder outflow obstruction, either of anatomic origin or of functional origin. Or we can diagnose bladder sensitivity abnormalities. A low compliance, I think we are going to discuss this today, and urodynamic stress urinary incontinence, and sometimes intrinsic sphincteric deficiency can also be diagnosed in our patients. So this is, of course, the most crucial point, how to utilize the data that we get from the urodynamic studies in our decision making.
There's a lot of diagnostic insights that we can find from this, and just to parlay off of what you said that we can diagnose, what are you really measuring? Like, what are the key parameters that you believe should be measured during urodynamic testing that really directly inform your treatment plans for urinary incontinence? Like, what exactly are you looking for on the urodynamic studies?
Yeah, thank you. This was again another question that we received several times during our webinar, how we are going to perform the urodynamic evaluation. So the first principle is that the urodynamic studies are never alone. So they are a part of the ICS urodynamic protocol that includes, first of all, a very thorough patient assessment, including history, physical examination, bladder diaries, and all the pre-urodynamic evaluation. And the ICS standard urodynamic test includes the free uroflowmetry, the measurement of post-void residual urine, and also the multi-channel urodynamic testing, which is also referred as invasive urodynamic testing. Oh, Melissa, at this point, do you have a protocol for this urodynamic testing? Because we know, of course, that all urodynamic testing should be performed according to the ICS standards. But from the practical point of view, what are the parameters during this study that we have to note and be careful about?
Thank you. I actually developed a template, and that would love to share with everyone who's participating in this video, because it is so important that we do it the same way every time. Now, sometimes we do it differently, but we want to make sure and capture all the truly important data. So when I think about urodynamics and what I'm trying to endeavor, first, we obviously are trying to answer a question, one of those aforementioned issues. Is there overactivity? Is there underactivity? Is there sphincteric dysfunction? But the best way to do it is go through the same process every time. So on that uninstrumented uroflow, exactly what am I looking at and how is that going to drive decision making? During the multi-channel study, when are the sensations? Is there a sensation of urgency? Is there overactivity? At what volume did the overactivity occur? Is it high amplitude? Is it low amplitude? Was it associated with leak? Is there a change in compliance? What are my abdominal leak pressures and at what volumes did I measure them? If it's a neurologic patient, then do they have a detrusor leak point pressure? And then again, when we do our uroflow or pressure flow studies, what is the PDAT at Qmax? What is their PVR? Am I looking for bladder outlet obstruction? We're going to speak about that because there were some good questions about female bladder outlet obstruction later. And then if I've used fluoroscopy, what are the parameters that I need to assess? This helps me keep in context every single parameter that I know that I want to look for during the urodynamic studies.